Okay, just to try and make it a little bit more real for you and kind of what I see. Case study, 76-year-old lady with back pain. This was a lady who had, real severe back pain, secondary to spinal stenosis, so bad that she had to get a laminectomy, so she needed a surgery on her back. Before that, though, she was tried on hydromorphone, gabapentin, codeine cotton, and it didn't work. So she went for the surgery, got it done, good results, but a year later, pain came back. And again, she went back to her physician and was started on those same medications that didn't help. So she was referred to me, and it was a great case because it was fairly straightforward. So none of these things had worked. We got started with where's one of those bottles? But a 10 to 10. So equal parts THC, CBD, oil. And again, I use a lot of the oils because I can dose to the milligram. So we started that with her just at night, 1-to-1. This is just something we use called the Brief Pain Index, but it also measures her kind of subjective sleep. So she had pain, she couldn't sleep. So this is when she came in. This was a month after. Her sleep was greatly improved. Pain was coming down. This is maximum and minimum pains. The really neat thing, again, is she slept great, pain was reduced, and it was consistent. So it's just highlighting, again, there's an alternative, and why wouldn't you try something like that with such a nice side effect profile when those didn't work? And I would argue, after you already tried one of those, why not try it? Again, given its great side effect profile. So that was a good case. I'm doing more work in long-term care, so nursing homes, because we see they're on a ton of medications. There's no secret. Older individuals, 10 plus medications, and what does that lead to? Negative outcomes. So polypharmacy or a lot of medications leads to poor outcomes for these seniors, 2 times more likely to be on opiates, 3 times on antidepressants. Again, so background, I'm saying this because cannabis is multimodal. So again, one of the nice things I like about it is that multimodal means you can capture a couple different things you're trying to treat, whether it be sleep, pain, anxiety with one thing, as opposed to a different drug for each indication. So again, for reducing polypharmacy in seniors, it makes sense, especially when you think they're 5 times more likely to be hospitalized for an adverse reaction due to drugs. And usually these big time drugs are cancer drugs or opiates. Unfortunately, with opiates, their risks come with people who have more comorbidities or more disease and who are on more medications. So that's when they are particularly dangerous. And again, that really falls into the senior population. A little bit of disheartening data from 2011 to 2016. We know this. We know they have these issues with these medications and these negative effects. But opiates among seniors, the heavy duty ones, the lower potency ones have reduced, but the heavy duty ones like fentanyl, oxycodone, hydromorphone have increased in that time period. And that just kind of blows my mind because we know we have this issue. We know they're dangerous, yet the prescribing's still going up. So again, just thinking about alternatives. That basically just kind of says the same thing. It's associated with adverse outcomes if you have more medications on board. There's a thing called the Beers list for medications in seniors that should be avoided. And unfortunately, 4 of the 10 most commonly prescribed drugs are actually on the Beers list. So our good friends, lorazepam and amitriptyline, basically no-fly zones are still very common as well. And that's where, again, we can substitute. We're getting better. That's just showing that the percentage of Beers list medications, the harmful medications to seniors, is going down. However, practically, it's not really doing anything. So they're reducing them a little bit, but we see that these interventions, there's drug reviews, which are pretty good for seniors in long-term care settings to help kind of go over medications that should be avoided or actually work with the docs. But clinically, it's not leading to reduced hospitalizations or emergency visits. So this is just kind of a quick little summary of what we tried to see if cannabis oils could actually help reduce polypharmacy and improve some of these outcomes for these seniors. So it's a small, quick little case series, but the data is really neat, and essentially 100% of the patients came off their antidepressants, so that was 3 out of 3. 100% of them came off their antipsychotics. Small sample size, 3 out of 3. Those antipsychotics was Seroquel in that case. The antidepressant was trazodone. The real neat finding is the big time players, fentanyl, Dilaudid, Percocet, 75% discontinued their opiate use, which is great. The only reason we didn't have 100% is because one patient came off all of their fentanyl but still needed a little bit of Dilaudid for a breakthrough. And sorry, that's more for the pharmacist, but it's still a talking point that, you know, reducing polypharmacy can have good benefits and is an option with cannabis. So we did see they were less sedated, they had better appetite, we weaned their opiates so their bowel habits improved. So there was a lot of other things that happened with reducing those medications that was positive as well. And again, it lends itself to that multimodal idea of doing more things with just one medication than taking a number of different medications to do the same thing.